We'd like to welcome you to AMI TV and to this episode of AMI Live, where real dentists discuss implant dentistry. This series is sponsored by the Academy of Minimally Invasive Implantology, or AMI, which is a nonprofit organization dedicated to the education and research to bring minimally invasive implant treatments to dentists and patients. My name is Steve Clark, and I'm the Chief Operating Officer of AMI, and I invite you to become a part of this growing community of AMI certified dentists. Today's session's live and it's being recorded for future on-demand viewing. And we have a large audience with us today, and we thank you for joining us. And feel free to use the chat feature and submit your questions during the session. We remind you that the interviews are posted on AMI Live TV or AMI TV, that's www.amiitv.org, where you can watch the replays of this along with the other sessions. So we're honored today to have Dr. Michael Miyasaki as our host of AMI Live. And today our guest is Dr. Shah, who's a practicing dentist, a mentor, and a well-respected implant educator. He is many, many other things, which we'll allow him to elaborate on today during his discussion. But he's currently hosting a popular daily global summit, which are reaching thousands of professionals all over the world. And once again, his bio will be posted in the AMI TV section for that, for your review. Dr. Shah is joining us today from Palm Desert, California. So now, without further delay, I will hand this off to Dr. Miyasaki.
All right. Thank you, Steve. I'd like to welcome our listeners to today's AMI Live interview at the Academy of Minimally Invasive Implantology. Once again, we're building a unique community of clinicians interested in incorporating the placement of implants into their practice, or who are already placing implants and want to offer their patients the very best. And you are now part of this community of like-minded colleagues, so welcome. So as Steve mentioned, we have everyone muted to minimize distraction, but we want this to be interactive. So we encourage you to ask questions with the chat button below. And I hope you've now noticed that these interviews allow you to meet our AMI educators and implant users who are just like most of you. And what we discuss is how they practice, how they started in implants, and what they're doing today. And I am so privileged to work with a fantastic group of AMI educators, and each one has practical, real-world knowledge and that true passion about dentistry. So hearing from each one always inspires me, and I hope you have been following our interviews to see that we have not only some great instructors and educators, but above all, we have some great people involved with AMI, and I think that's the best part. So we hope you enjoy this series. Go out, grab a cup of coffee, a drink, and let's learn together. I don't have this next part memorized because I told Dr. Shah I wanted to do them right. So Dr. Shah, DMD, MBA, FICOI, FIA, DFE, MICOI, FCII, FPKP, FICD, DICOI. And if you go to his website, he sees he's part artist, part surgeon, part architect, part businessman, part entrepreneur, part therapist, part physicist, and part community friend. He's also the founder of the International Extraction Academy, founder of the Global Implantology Summit, which Steve was mentioning. Dr. Wong presented on that this past week. And Dr. Shah is also, above all, a family man. And I've had the privilege of spending days sitting next to the guy as we both learned more about implants. And I will tell you that he is what he professes to be. So I am excited to be here, and I've been looking forward to this ever since we kind of scheduled this. So I'd like to welcome our listeners to today's interview with Dr. Shah. And I am going to let him tell us more about himself. So Dr. Shah, welcome.
Well, thank you, Dr. Miyasaki, as well as Mr. Clark, for having me on the show today.
It's great to have you on. So let's start out with, before we get to all the heavy dental stuff, because you're well accomplished in business and in dentistry, tell us a little bit about yourself. Who are you? What do you like to do? I heard table tennis?
Yeah, I do a little weightlifting, a little table tennis. I tend to spend a lot of time in walking and pondering about the important things in life.
So do you walk or do you run?
I don't run, I walk. I sometimes walk for 2 hours at a time, or sometimes even 3, and just plan my day, or ponder issues that are going on, or projects that need initiatives, and accordingly execute.
Wow, that's great. So why don't we jump into how you got into dentistry, where you went to school, when you graduated, and just start at that level, and then we'll build our way up. I'm interested to learn more about you.
So I wanted to be a cardiac surgeon and ended up being a dentist. Actually, I spent some time in undergrad volunteering at a local hospital, and I saw the lives that a lot of the surgeons there were carrying, the issues they had with families, and I kind of also wanted to build a family. So my best friend was heading to dental school, and he was a year ahead of me, and he would tell me about all the wonderful in dental school, the things that go on in dental school. So I applied to one dental school and got accepted, and that's how it all started.
Wow. So how was it? Has it been what you were hoping it would be? It's like a big shift of plans there.
Yes, I think our profession is very unique. We are a lot more autonomous in the way we do our patient care, as well as run our own businesses. And we can have a good balance of family life and professional life, but that's not necessarily true for all professions.
Yeah, I guess if it went back to your introduction, we would have just said you were a surgeon and an educator, and that might be about all you had time to do. But yeah, you're right. I would say you're an overachiever in everything you do.
But Doc, we are really, we as dentists, we have to put on so many different hats between the business and being an artist and creating things, and the engineering concepts that we have to know, and the community involvements that we have, and the goodwill efforts that we do, and on it goes. We have a lot of hats that we put on every day.
Yeah, absolutely. And now talking about dentistry and the way that you practice, you don't necessarily practice like most of us. You do some traveling and you do the education and you do a lot of teaching. So can you tell us a little bit about that?
I like to think outside the box. I'm in an environment in the town that I'm in where there's an abundance of doctors. So when you're in a situation, you have to do things differently if you want to have the patient flow. So on a strategical level, I only practice usually on Saturdays and Sundays, as well as Tuesdays, to absorb some of the emergencies and some other things that I do. And if I have full mouth rehab cases, I bring them in on the days that I don't have anybody, any other day of the week, that I can bring in an anesthesiologist, and we can do these full mouth rehab cases. So 3 days, weekends, during the week, I focus on all of the businesses, activities, research, all of the other international projects I'm involved in. That allows me to balance the business side as well as the dentistry side this way.
Yeah, that's really interesting. So how do you, your office, you have it going 3 days a week? Do you have an associate or a partner, or is it just you?
No, it's just me, and I'm doing better out of 2 dental chairs than I did when I had 6 offices and probably over 20 chairs. No, maybe 30 chairs, over 30 chairs.
Wow. And just doing more high quality work, or what do you think makes the difference? Is it just less management headaches, or I'm kind of interested in that?
At the time, I was so overwhelmed with HR-related issues, having 12 doctors and 80 staff members, and there's a certain things that happens that after you have 5 offices and you go to 20 offices, then you go to, it was not for me. Now, all the monies I used to generate got sucked up by all of the different overhead, and I couldn't execute like I do now. Having that relationship with a patient and taking your time, I have learned personally in my career that it pays off a lot better than jumping from room to room and numbing people and trying to build a dental office empire and all of those things that we see now happening in our industry. But the one-on-one patient, spending some time with them, joking with them for the first half an hour, just getting to know them, building a rapport, establishing rapport with the patient, tend to pay off a lot more than the other way around.
Yeah, no, I absolutely agree. It's you know, the interesting thing is, as we've done these interviews, you know, all the educators and just us as dentists in general, we all kind of practice in a way that we feel comfortable practicing. And, I think what we've seen is a lot of the highly successful dentists are the ones that don't have, a lot of offices. I mean, they spend the time with the patients, they build that relationship, and they provide the higher end, I guess, types of treatment. So it seems like a common thread running throughout, but that's great to hear. It's very refreshing. So let me ask you this, because of the design of your practice, it is unique and a little bit different than most of us have. During this, to make it relevant, we're going through and hopefully ending, I don't know, this COVID isolation that we're going through right now. I know you're down in Southern California, and this COVID, this shelter in place may be extended for you. How do you think this is all going to pan out? There's going to be challenges, but there's also going to be opportunities ahead. Do you have any advice to give to our colleagues, because you are kind of an out-of-the-box thinker?
The first item that you brought up was California. 2 days ago, they have extended Los Angeles County for another 3 months of quarantine.
3 months.
I personally, with an MBA background, I don't know how a business can survive being in quarantine for 5 months. And there's not enough money that the government can give you to keep those obligations alive. So we are all startups. After I got done with my 6 offices, 4 of which I built from scratch, I've helped companies and doctors build over 30 startups. And startup strategies are a lot different than what you expect. Right now, vast majority of us are startups with a patient list that we have. Startups take 4 to 6 months to develop. It's not, if you think that you're going to open a door and they're going to flood in, you're completely mistaken. It's going to be a process. You're going to encounter a lot of issues with patients that don't want to get dental treatment during COVID. When you call them, you have to have your own blueprint and strategy as to how you're going to go to market when you open up. Medicaid offices, good luck with the $59 extractions or $49 extractions that you get on government aid programs. You have to have certain protocols, only see 1 patient at a time, maybe 1 in the waiting room to minimize your risks. But at the end of the day, the insurance, if you have a mix of insurance or if you're a fee-for-service, you have a lot of maneuverability to get back up. So it creates an opportunity for certain groups. But a lot of our colleagues don't have the skill sets to operate as a standard startup. A lot of them either acquired a practice that was functioning at the time when they bought it. So it was a quick decision of keeping the owner on or not on, or as an ambassador, or however that was. But this is not the same. We're sort of all startups now. Some are going to market aggressively. One advice I could give these startups is to think strategically. You've invested monies over X amount of years that you have had your practice in some marketing venues. A lot of them were dark holes and didn't generate you the kind of patients you wanted. But I'm sure you can recall the ones that actually did generate patients for you besides your list. And I would heavily market in those venues called sampling in the business world, pulling and sampling. So marketing, the dollars are limited and every dollar is going to count in your marketing budget. So I would recommend that you have a plan for your marketing. You have a plan to gradually bring staff back. Depending on what sort of loans you took with the government, what the stipulations are there, it might be different for some or another. I didn't take any of those loans because the story completely changed from the government, from where it started to where they started dispersing the loans. And I decided to use savings to survive this pandemic. Some didn't. Some thought it was going to be free money, but it's not. And they have to build a blueprint for their practice and very strategically think this through. When we did startups, you would operate out of 1 chair, then 2 chairs, then sometimes you wouldn't even build the back out and block it off until the revenue of the practice justified such an expansion. So keep all of those things in mind as you design your blueprint for your practice.
Yeah, no, I think all those words are well taken. It's a time to be cautious. We don't know how things are going to pan out. Like you said, I've talked to some of our colleagues and they think, they're going to be so busy when we get back in the office, and others think it's going to be a slow ramp up. But I think it's better to plan for the slow ramp up and experience the big rush than to plan for the big rush and have a slow ramp up. So I think those are wise words.
There is a possibility though, doctor, that there might be, for some practices, they might be very busy.
Yeah.
I wouldn't exclude that. That is a certain possibility, yes.
So if we do have this kind of change in our patients thinking right now, do you see any opportunities where you think a certain market will do better? You're the business guy and dentist. Anything that you think we should focus on?
I think right now, your bread and butter are going to be your emergencies. Until the vaccinations come out. It's going to be a tough road. It's going to be a tough road ahead. But then again, the hygienists are going to suffer tremendously financially and work-wise. They would prefer to stay on unemployment versus actually going to work where you get their hours cut and patients don't show up and schedules fall apart and all of that good stuff. They're actually number one. It's actually the number one on the list is dental hygienist stuff. Yeah. And then third is us.
Yeah. Well, so I'll tell you, we being up in Northern California, we've had some of the restrictions lifted, and we've been kind of easing slowly back in. And it's funny, I tell our colleagues that even if unemployment, let's say, is 20%, there's 80% of the people that haven't been affected like we have been. And so I tell our colleagues, still go on with that thinking of abundance. Be cautious, but go on with the thinking of abundance. Because I've been talking to patients, and I go, so how are you doing? And they go, I'm retired, and it really hasn't made a big difference. Their income's the same, and they're staying at home basically is what they do every day. And I have other people that are working from home because we have a lot of telecommuting type of businesses up in Northern California. And so, their incomes haven't been affected like others. And so we've gone back in, and we've gone through, because of the shut down for 6 weeks, where there's been some teeth that they just snapped off, or there's been some that have gotten infections. And because of the poor prognosis, we've talked to them about implants, and a lot of them are still very open to implants. So I think you're right. I think for some practices, the focus is going to be a lot on emergencies, but hopefully those emergencies, as far as, the practice well-being, will turn into some implants, and we'll get to do more of this. So, Dr. Shah, as far as implants, how did you get into this as far as implantology? Because you're into teaching the tooth removal and the tooth replacement phases.
Yes, I remember in 2018, I always loved to do wisdom teeth extractions and full mouth extractions, and it always came natural. That's why we also started the Extraction Academy, because a lot of colleagues don't have that experience. In implantology, what you notice, all of these courses and education, a lot of it is about who's the best implantologist in the world, and nobody is really sitting down and looking at exodontia and the foundation of what we do for implant placement, the way we think about it in the long run. So there wasn't enough courses in exodontia, so I got into that. But in 2018, Camlock walked into my office in Southern Illinois at the time and said, "Hey, Henry Schein has this course up north, and here's I believe it was a very small tuition to go, and you would get training for 2 days and kind of get an idea. When you sometimes get that feeling that this is my calling, and you're sitting somewhere and something snaps, and that's what happened to me at that course, and I made a career out of it."
So you incorporate implants. How was that? What did the patients experience when you started to do implants? Did they like it? Was it scary to them? How was it?
Well, it all comes down to patient communication. I mean, the idea of having a scoop threaded into your jaw is devastating for a patient. But if you sit down and explain how easy it is and how less painful it is than filling a root canal at times, and have that a dialogue with the patient, it's a different story. But just like anything else, it's a learning curve. You remember when they taught us how to do root canals in dental school? It was central first, and it was lateral, and it was a canine, and you sort of moved yourself into the premolars and the molars.
Yeah, I remember that.
For people that are starting off, case selection is very important. You're not gonna go and do an implant on a 2 millimeter ridge in vertical height. You're gonna do the central or something that is um, easy to do to get your feeling into it and get started.
Yeah. Yeah, you know, it takes a while to get the skills and the confidence up, and then you tackle tougher and tougher cases. And as you gain that confidence, I think, yeah, it's easier to talk to your patients and be calm about it, and then get them to say yes.
Sorry,
So,
I think I said 2018. It was 2008.
oh, 2008. Okay. Yeah. I was thinking, well, you're really young then.
No, I wish. I'm going 40 this year.
Oh no! Wow, it's a great age. So overall, you said you started with Camlog, and you've been doing this since 2008. And were you always with Camlog, or did you try different systems? Or was there an evolution in that, or what's happened over the last decade?
So once I gained that skill in Illinois, and took a lot of CE there as well as in California and other places, my wife and I moved to California, and I started the MBA. And in that time, during that time, I was practicing and jumping around offices. I must have practiced in over 300 offices, doing all of the second molar endo and all the wisdom teeth and all the implants. And so a lot of these doctors had either kits or would be pursued by one company or another. So I had to work with just about all of the major systems in one capacity or another. It got to a point where I would be able to look at a system for a few minutes and be able to go into the operating room and place an implant with it.
Wow. What do you learn about all the different systems? Are there pros and cons to each one, or were there certain favorites you always had?
We should talk about that in more detail. There's a lot of little concepts that each implant company claims to have a better solution for, but while they fix one solution, they create another solution, create another problem.
Yeah.
The next guy fixes, and on you go. There's over 1,200 implant companies now in the world. But there's nothing like Ami's IBS that I have explored. That's a very unique one.
Hey, you know, we talked about this in some of the other interviews. You can pick out a system that can be a great system, and you go to a course, and one of the stumbling blocks, it could be implantology, it could be aesthetics, it could be, you know, whatever it is that's new to us. But we go to a course, and we're kind of smitten by that system, you know, and everybody around us is excited about it, and we buy into that system. And I don't know if it's ever happened to you, but there's a system that I bought, probably spent about $25,000 on that system, and then never really used it out when, you know, once I got it back to the office. Like you said, it takes, you know, you can learn it, you can do it on models, but there's some confidence and some further skills that you need to create. And is there something you could say about that? Like, I like Ami because Ami, again, like what we're discussing today, it really is a community of support that I think really helps with the integration. Do you see differences there?
Well, the support is tremendous. I mean, I've had Ami and the IBS individuals multiple times come to my office and work with me on cases or show me different things, and be it surgery, be it a business discussion, be it some initiative I could do for my office in my local community. So that has been non-existent. Usually salespeople come in, they say, here's our deal, and we might throw you a couple of free implants or something to get you sucked into the system. And once you're in the system, you're in their system. But to have that relationship, we're just like patients. You know, when people come to us and establish a rapport with us and there's trust, then we are more apt to explore their products. That kind of service I have not had before from other implant companies.
And now you've been using the different implants from IBS that are incorporating Omni, the procedure of being minimally invasive. And how's it been working out for you? Do you like it as good or better than other systems, or what are your feelings?
Yes, I'm very, very attached to it. And I was actually having a discussion recently with IBS that I want to continue exploring some other implant lines that you guys are coming out with, or you have come out with recently. But I'm very quick now to change my mindset. Some of us still, probably people that are here, there might be one or two that's still using a flip phone. But every time you have a big idea that comes around, it changes an industry. People are at first very resistant to it, but you have to change your mind setting. I'm very, very fond of flapless environments. Have you seen some of these flaps they make for guided surgeries where they buzz the bone down and you got pins sticking everywhere? This is traumatic stuff. I mean, this is some hardcore stuff. I used to do those cases that way, but I don't anymore. And patients are asking for minimally invasive procedures. There's two areas we're going to see a big growth in dentistry and medicine. One is regenerative, and the other is minimally invasive. People are asking about minimal invasive procedures. You got to start acting and catering to their wants and needs. So yes, I'm doing implantology quite a bit differently now in my practice. And my failure rate is almost non-existent.
That's great. You know, we'll get into the system and how you're working with it, but maybe we can backtrack because I think you're right. You know, the IBS and Dr. Wong is quick on his feet, you know, being a dentist and an engineer, just kind of a man just like yourself, and you're both successful business people. Do you think that makes a difference as far as the direction that IBS and AMI are going in, and as far as the future of AMI and its applications?
Yes, I think that engineering background of Dr. Wong has a tremendous influence on the system. The direction of this organization, I think, is just bound to grow. AMI is starting to become known in many circles. And only time will tell how many colleagues it'll be able to reach. But also IBS is constantly growing because people are starting to understand and step out of the box to think, hey, is there possibly something better than what we have been seeing?
Mm-hmm. Oh, absolutely right. So let's go into the system itself. You know, I know you've got that engineering mind. So can you tell us about some of the design features of the implant system? I mean, you know, we could have viewers on this program that have never placed an implant. And then we have those viewers of this program that are experts at an implant system. And as you're saying, you know, sometimes it's hard to leave something you feel comfortable with and try another system. But I know your mind, you like change. And so if you had to convince somebody who's maybe using another system, is there some tips or things you'd point out to get them so they would consider trying this one?
Well, let's look at it. All of our colleagues that are here that have ever been to an implant conference of any kind will sit there for hours and listen to different lectures from different experts talking about the same kind of topics: micro pumping, leakage, angulation, the difference between an external or internal hex, the conical hex. What are the benefits? What are the pros? What are the cons? Screw loosening, cement retain issues, how to mitigate all those problems. But to create one implant that can solve it all is likely impossible. But there are ways to get very, very close to having all of those features. And although the Magic FC system is a bone level implant, I'm in love with the idea of the threads, okay? Mm-hmm. I'm not much of an osteodensification guy because you can always under prep a socket and you can place an implant for your initial stability, okay? So you don't have to cause more trauma and drilling and water and all of that stuff. So I'm sort of the cut a smaller hole and press fit and that type of thing. So this is a good scenario for me, because even in the Magic Course scenario, we are creating a fit press. We're very, very minimally invasive. And even with the FC, if we need to engage and get tremendous 50, 60 newtons worth of initial stability, we can achieve that by under prepping and using the fin threads, which are very much blade-like. That as to the FC. As to the Magic Core, I want to kind of talk to you about, I got one of these at one of our conferences. I don't know how well you can see it, but I want to talk about the issues that we mostly talk about at conferences. Our biggest challenge in implantology is perimucositis periimplantitis, because bacteria grow into the holes where the platform of the implant is that connects to the prosthetic part, and they cause bad odors and bone loss and all of that good stuff. So every implant that's bone level is going to have a level of micro leakage and micro pumping. Mm-hmm. If somebody tells you that there's not, it's untrue. Because you have a break in the metal, it's bound to happen. On a microscopic level, it's inevitable. Some connections explain that they have a Morse connection and somehow that resolves the issue. Not true. Fact of the matter is, if you have a break at the bone level, you'll always have this issue. Okay. In my opinion, my humble opinion, after listening to thousands of hours of this stuff. So here we have an implant, this magic core, and I'm looking at it, and I'm just from an engineering perspective, I'm looking at all of the issues that I learn about at these conferences. So if this is a tissue, let's just say this is not a one piece or two piece implant. I call it like a dual function type implant. Because we have everything in here that we're going to address. But for example, the fact that we are not at the bone level and we have a cuff and we allow for good soft tissue adhesion and also thickness with our neck here is a wonderful thing. So you cannot actually, it's impossible to have bacterial ingrowth and micropumping. Would you agree with me?
Absolutely. Yeah.
Very good. So why do we have internal hexes and external hexes? There are more issues with pumping on the external, but it has some benefits. The internal has some benefits in terms of angulation and emergence profile. This is sort of built into this implant. And the fact that we have not only essentially an internal connection, internal screw retain connection, but we also have a conical type hex in here that will allow us, again, if you have a screw at the bone level, okay, when you're applying lateral forces, the screw will get loose a lot of times, correct? But when you have your screw further up, the lateral excursive movements and your vertical movements aren't gonna go to that screw. They're gonna go to that neck that we have a solid metal on. Would you agree?
I agree. Yep.
Impossible to knock the screw. For those that like screw retain restoration, here's your solution there. For those that like to have cement retain scenarios, they have that function here as well, restorative. So now naturally, it gives an option for both people that like cement and screw retained to eliminate that argument, because it will be the choice of the clinician. And with the angulation scenario, you're able to change 50, 60 degree angulation differences with this particular implant. So for me, between the micro pumping, the micro leakage, the elimination of perimucositis, the solution to angulation and the connection, the prosthetic connection, and also having the ability to have screw retained restorations is mind-boggling, considering that most dentists that I know like the screw retained route, and the bigger companies like Nobel and Straumann and all those guys go lean more towards screw retained restorations. Makes it a very exciting matter. I was asking Dr. Wong if he could somehow get a wash machine or something in here last time I spoke to him, because it has all the features that we need to be able to do our job better and more predictive. And then, you know, when you're not constantly taking healing caps off and putting them back on where the soft tissue attaches, it attaches. You don't break up those fibers. Once it attaches, it attaches. It doesn't keep coming off and on. When it keeps coming off and on, you create problems with your biological width, and then you go to your x-ray and you get bone loss, or you have soft tissue loss, or you have pocketing. And these are very, very important concepts. If this implant is in a position to eliminate perimucositis and periimplantitis, wow. That's a big wow in the dental industry.
Yeah, so you like the implants.
I like them a lot. I haven't placed anything but IBS implants for at least the last 7-8 months.
Yeah, well, that's great. Well, no, I like that. And I know you're a guy that I mean, right off the bat, you analyze the design and kind of pick it apart. So it means a lot that you do like it. One of the questions was, as a clinician, what would you say the top benefit of minimally invasive implantology among all that we can list? So, are there, when we hit that part of the question, so the benefits to you as a clinician, what would you say? I mean, you say you like it because it is conservative. What are some of the other things? And then we're going to ask you what are the benefits that the patient sees from the OMNI approach. So maybe start.
I mean, the pain issue is a big one for me. I
Okay.
have very little post-operative discomfort, very, very little, and often none. As far as placement for me, I love my initial stability. I have been, after exodontia, a lot of times I find a root that has it's a natural guide. And you have these fins that are thin and really engaging into the bone. You have initial stability, which means initial restoration if you can possibly pull it off. I just did one the other day on an anterior tooth. That for me, initial stability is a big deal. I mean, you can't just drop an implant into a socket and hope it ossifies, right, or integrates.
Yeah.
You want initial stability, a complete initial stability.
How about, do you notice, this is a question, that if because you are doing kind of a minimally traumatic extraction, and so now the bone bed is ready for placement of an implant, do you find that the burrs that we use, the drills that we use with the IBS system, make that easier to do? They're not your typical twist drill, they're more of a trephine type of drill. Does that make it easier for you post-extraction?
Well, speaking of the burrs, even if you had an extraction site and due to the indentations and the missing parts in the metal, does it not only collect bone for you that you can mix up with your grafting material if you like, but it also allows you to move laterally very easily. I urge you to try that sometimes with the IBS burrs, that if you had, for example, an anterior tooth and you wanted to lingualize that implant for aesthetic reasons, you can simply, with much control that you won't have with other burrs, and the bone also goes to waste, you can, with much control, move your osteotomy site from the natural tooth root side, even if you did a wonderful extraction, and move it lingual, move it lateral, move it mesiodistal, whatever it is that you need to do to get a proper angulation.
Yeah, I think the drills are really unique and they really help with that part. And then you were saying from a clinician's standpoint, failure rate basically kind of just drops off because of the stability that you get in the atraumatic approach. So from a patient's perspective, what have you noticed? I mean, you've been placing the implants for over a decade and you've had a lot of feedback post-operatively from the patients on how they're doing. Do you see a difference using the system?
Yeah, they leave me a lot of good reviews. And patients are a lot happier when I can restore them faster. You know, people don't like to wait 6-8 months running around with a flipper or some sort of a tooth that you have bonded to the next tooth and what have you. So in a lot of cases, I can probably restore within the first 3 months rather than waiting for the entire 6 months that the literature says is the best time for integration. So, you know, they always taught us that you sit down and you put the implant in and you wait for the bone to grow around it. With this implant and this fit design, you're going to the implant. You're not waiting for it to grow to your implant. And one advice I can give doctors is that never walk away from an implant unless you have initial stability, because it will fail. There's a very likelihood that it will fail. So with that said, if you have a better technique, you have fast restorability, limited invasiveness, no flaps, no sutures a lot of times where you don't have to graft, the only inevitable outcome is happy patients.
Yeah. So I think I really appreciate what you said and all the pointers you've given us. And just looking at the design, I think you're absolutely right. It's pretty amazing how everything has been so well thought out. I guess the next, you know, because we want this to be helpful to our listeners, So we come out of this isolation, and man, I didn't know you guys were extended out until like August or that far. I know Southern California's had a lot more cases than we've had up here in Northern California. So let's say we get through this, and some doctors are getting out of it, depending on where they are in the country. And you were talking about having the verbal skills to get the patients engaged in this type of treatment. Can you give us some advice? Because I know you're a skilled presenter at these types of treatments, the larger treatment plans, like you're saying, you do full mouth rehabs and all that. So we sit down, and perhaps the patient's got a bombed out tooth number 30, and after they put it off for 3 months because they've been sheltering in place, we can't save that tooth. I think the other fear that, when you get into implants, it is an investment in the surgical kit and the training. And I, as a clinician and a practice owner, I'm always worried, well, am I going to get my money back? And, and you're right, we can get trained, we can have this great community, but if the doctor's not skilled enough to make the case presentation, it's never going to go. So I think that's where I can really get a lot of information from you, because I know you're good at how to talk to the patients.
Well, there's two types of dentists. Some dentists that work by the book, and some dentists that have a personal touch and feeling that comes with it. Let me ask you a question. If you went to it's very important to be different, okay? Not to just say you're different. To be different. You're different with this implant system in our office. Let me ask you, if you went into a bar and there's 100 guys standing around, and there's one girl at the bar, and you go up to her and you're trying to make a friendship or possibly even ask her out. You go up to her and you tell her, "Hey, listen, I'm completely different than the other 100 guys in here." She's gonna look at you and think that you're a slime ball, right?
I hope not.
So just saying different is not the same thing. Being different is the same thing. You have an implant that's less invasive than any other implant out there, and that is using a completely different protocol, and how you market it to your patient is very, very important. How do you make a patient understand that has never seen an implant what the benefits of those things are? You have to emphasize the things that they understand. Like, hey, you might have heard from your friend that implants are invasive. You have a brand new system here that we are working with in our office. It takes a lot of those things away. It takes the pain away, and all of the things that we have really discussed in this session today. And formulate that in a shape or form with the models that we have that are also company sponsored, to demonstrate to them what's going to happen to them from start to finish. Treatment planning is an art, and it's not about you telling somebody that you cut the best 6-degree preps. They don't care. They care about cleansability, somebody smiling at them at the front desk, and not being hurt. That's their biggest concern, is coming to dentists, not to get hurt. They don't want to get hurt. So when you have a product that's going to tell them, hey, if you do this properly, you're not going to be hurt, that's good news for a patient. That's a good start. So you have to formulate your sales pitch for those that need this treatment for whatever reason, and you have to master it, and it takes time.
Yeah, absolutely. And a couple interviews ago, we were talking about the team. Do you feel like you need to have a good team behind you to support you as you do these larger treatment plans, and then taking care of the patients in a way that I call it being remarkable? You talk about walking into the bar. If there was something about you, and there would be something about you if you walked into a bar, and compared to 100 other guys, I think you would stand out. You're remarkable in a way, and I think
I would first buy her a drink, I think.
Yeah, but you'd pick something that would knock her feet off, right? That would be, wow, this guy's remarkable. But right. I think that's the big part. And it's not really a one-man show in our practices. It's the person that answers the phone, welcomes the patient in through the front door, and today doing temperature and kind of making them feel like they're safe and they'll be healthy when they leave the office. Do you find that as far as integration, that having a well-trained team helps with you and your success?
The world of efficiency and efficacy builds around systems building. It's all about systems building. So with time, you're going to create a system. I'm not a big corporate guy. I'm not a big fan of any third party that has come into our profession, including the insurance companies and Big Pharma and everybody else that is in our operatory is constantly interfering with our patient-doctor relationship. My belief is that if you have a good team, a good office manager, and some good floor people, your assistants, your treatment plan coordinator, if you have one, you're set and you're free and you have autonomy and you're building equity for yourself, not for somebody else. But if you build that team, it starts with morning huddles. You plan on, if you know that you have a consult coming in for an implant, you have to have a system. If you send random people in there to present a treatment plan that don't know the system in your office, it creates a problem. For example, sometimes hygienists tap the patient on the shoulder. If you have a hygienist in your office that does initial exams or the emergency scenarios, and you come in and you look at the x-rays and you provide a scenario for that patient and treatment plan. But your hygienist can always establish, they have really good relationship also with the patients. They can start explaining things, maybe even put on a video about IBS in front of the patient. That the patient can watch before a doctor comes. The more information they have, the less you have to exert effort chairside to close the treatment plan, as well as to explain things to the patient and get them to understand and convince them. So your system is very important. I like, against all odds and all recommendations by dental business organizations, I still like to go in and talk to the patient about their treatment plan. I don't like other people presenting it. I don't like a treatment plan coordinator because I understand what it means. So when a patient has a questions, once the treatment plan is designed, I can immediately answer it. And I have a whiteboard. I get on my whiteboard and say, hey, this is bone loss, this is how it works, this is peri-implantitis or what have you on the scenario. A lot of them ask great questions and the other ones have total trust in you and say, hey, go forward with it. So you have to build that system and you have to implement it in the system in your office the way you like it. But AMI is very supportive on providing information that you need to accomplish that.
Yeah, and I think you made a lot of great points during that part. Yeah, I like that you're the one that goes in there. You know, a lot of times you go to a course and they say, well, the team has to be trained to do all the talking. The doctor just does the diagnosis and leaves. But like I said, the nice thing about doing these programs is we get to hear how so many different colleagues run their practices, and sometimes you feel like if you're doing it differently, maybe you're doing it wrong. But you know, if it works for you, like in your case, it works great for you to do the presentation and kind of close the treatment plan. I mean, that's great. And
it works for me. I mean, yeah. I have a certain approach to it. I tried doing all the systems building around that, but in my opinion, if you're not salespeople, you have an education and training behind us, and everything we're doing and presenting has a meaning. So patients, especially if you sit there with a patient and go over the treatment plan and then go back to your chart and sit down and say, hey, I sat down with the patient and I went over the treatment plan and I got consent for that treatment plan and they signed off on that treatment plan. If you ever end up in trouble, there's no issue about consent and there's no issue about lack of providing enough information to the patient, no matter what document you push in front of them to sign as a consent. The consent is a very complex matter. It's both verbal and written ultimately. Yeah. It's not just giving somebody a paper and say, hey, sign here. They're gonna come back at you and say, how much time did you spend with this patient? What kind of questions did you answer for this patient? And if you don't have answers for those and your assistant gave them a little sheet to sign, it's meaningless.
Yeah, absolutely. You know, I think you made another good point that, you know, we're not selling. I think what we're doing is
educating.
Sometimes we lose sight that the person we're talking to isn't another dentist. And, you know, they could be missing a tooth and it's been missing for the last 30 years and no one ever sat down with them and asked them, hey, how do you feel about that tooth being gone? And then the patient will say, well, you know what, I don't like the way it looks, or I do find it hard to chew, or I bite my tongue because my tongue goes in that space. And then you're right, it's not sales. What we're doing is we create awareness and then we offer them a solution, and it's up to the patient to decide, you know, do they like you, you know, do they find you remarkable and you know, trust you enough that you can go ahead and place that screw in their bone. I think it really is not sales at all. It's just we're creating awareness that there is a solution for that tooth being gone, and this solution will help to maintain bone, will help to hold in a replacement tooth that will keep the tongue out of the way, that'll improve the chewing and improve their smile. And, after that, yeah, you're right. It's not sales. We don't do it, I don't think, for the money, but we do it for the betterment of our patients. And then there's just fair compensation for that.
Correct. And I believe it's part of our duty to present and discuss and obtain good, clean consent and do all of those preparations before we get started. You know how many, you made a big point. Do you know how many patients I get every month that I probably don't have no count, but I hear it all the time. Well, nobody has ever mentioned anything. Nobody has ever mentioned anything. You have an edentulous space on a molar, and it's been sitting there for many years, and nobody has ever said anything. I mean, yeah, that happens. Some dentists are older, they care less, they come in, they're on their way out, and they don't do dentistry like they did when they were 20, 30 years old. I mean, for crying out loud, I was screaming out probing numbers when I got out of dental school,
Yeah.
sitting there, and the owner dentist at the time, I was an associate, he's like, what are you doing here? I'm like, this is what they taught us in dental school. He's like, oh yeah, let me show you how this is done in the real world.
Yeah.
So that fades over the years and decades of practicing. And at some point, they don't care anymore. So these patients, it's important to bring those issues up. Whatever you see in the mouth that you think the patient would benefit from, it's your duty to let them know.
Yeah, no, absolutely. Let me ask you, because, well, you might have some time if you don't open your office for a couple months, but, talking about the team, the systems that you like in place, and then maybe reaching out to the patients, because I know you know a little bit about teledentistry and some of those things, and what some of the options are there. So let's say you're going to be shut down for another month, and hopefully it doesn't go beyond that, but let's say it's another month. Would you say now is a good time if a doctor's watching this and they're honest with themselves and they really don't have a good system in their office to talk about larger treatment plans with the patient? Do you feel now would be a good time to develop those systems and maybe have webinar meetings if they can't have face-to-face meetings with their team members?
As soon as COVID started, we started deciding to move our conference, our physical conference, online, where we were planning to bring in 100 guys from 70 countries to educate and train in an interdisciplinary approach. We immediately did that, and in the last, I've been at it for 30 days now, exactly 30 days today. And we have burned through a lot of conferences with world leaders, and the idea behind that was exactly based on the same idea that you have. If you're locked down, and we know that knowledge is power, and we want to better our businesses and ourselves, what better than doing all the things we always wanted to do on the computer and the books and everything else that we never have time for? It's always there in the back of your mind, but you don't have the time. So we have had hundreds of thousands. I think we crossed the 700,000 mark yesterday. Of doctors and dental professionals that have tuned into our webinars in that capacity, and doctors are using, a lot of doctors are using the time wisely to improve themselves and be prepared. If you are interested in this particular program and this implant, I would highly recommend that you put aside some time in the quarantine season to familiarize yourself a little bit more, and also talk to other doctors that are using this system and using this product and using this whole ideology of implant placement to understand from their experiences, because it's just a matter of time before minimally invasive implantology will be the most prominent venue for implantology.
Yeah, no, I think you're right. I share with doctors, I go, with aesthetic dentistry, went from crowns to prep veneers to no prep veneers, and we became very conservative. Endo's kind of doing the same thing with the access. I think it's just a natural movement that in implants, we try to be as conservative with the patient's tissue and bone as we can. I want to hit what was the number that you said have attended your global symposiums?
They're over 700,000.
That's what I thought you said, 700,000. That's amazing. I don't think we hit 700,000 with this program. I think we're just maybe a dozen below that. So, but we're going to get up there.
Let's see if you can catch up. We are hoping to reach 1 million of our colleagues with complimentary material information that they can use for themselves in the most distant places of the world and in every discipline and specialty of the profession of dentistry.
Wow. So that's, go into that just a little bit more, if you would. Just again, you started this. I know you're very well versed in social media and just how to do this global outreach through the internet. And now your organization is about everything in dentistry.
So it's called the 2020 Global Dental Interdisciplinary Summit. We all need to be aware of all of the disciplines of dentistry. And we have pedodontists, periodontists, orthodontists, medical doctors, oral surgeons, researchers, PhDs, and down the line it goes of different disciplines of dentistry. We have maxillofacial radiologists, and on, every specialty, right? So pros guys and others. We have to listen to everyone's perspective. You know, the endodontists don't want us to extract, and if we don't have to extract, we should explore those options to render, you know, endo. You have to look at the orthodontist that says, hey, don't put that implant in or that bridge before I finish up my thing. Or you got, every discipline has a different perspective to implantology. When the endo guys are done with it, we take over. Yes, I understand. But ultimately, you need to understand where they're coming from, what their newest techniques are, the newest information that they have. And with the COVID thing, us being all locked down, a lot of our colleagues don't have either the finances, the ability to travel, or access to this information. I mean, we have people from Afghanistan tuning in, and the most distant places in Asia and Latin America and Europe and Africa. And to be able to influence or facilitate this information to them free of charge and complimentary is a beautiful thing. Some people invent things and affect millions of people's lives. Some people create a platform where 1 million doctors or healthcare professionals come to, and they subsequently affect the lives of hundreds of million patients or even billions. And that's a wonderful thing. It's all peer-to-peer. I launched that back in my days in MBA. I got involved in peer-to-peer concepts in the financing world, and I lectured for them in Shanghai and in San Francisco and other places. And it was all about blockchain and peer-to-peer facilitation of business. And the idea was to use technology to eliminate third parties and have interactions between two people without all the politics and membership fees and all of those good things that come along with it. So I saw that it boomed and exploded. What was 100 guys in a hotel in San Francisco several years ago, 7-8 years ago, actually, has now turned into an international sensation with blockchain and literally thousands of different concepts that have come out of it that have made our lives better. Now imagine being able to implement and apply that to healthcare or peer-to-peers. This whole entire conference, there's over 150 some doctors right now actively working on it, and a good chunk of them are working essentially like the clock. Nobody's getting paid. There's no financial interactions going on. Everybody's donating the time and goodwill effort because they want to achieve the goals of this vision of this project. Anything is possible peer-to-peer. I just put an example on, and it exploded into the largest global summit in human history. Not just in dentistry, but in any other industry. We're uncertain of any conference where you've had 700,000 people go to. So it's an example of what peer-to-peer, the power of peer-to-peer can achieve. And as you know, similar things are happening at AMI, where we're creating a lot of peer-to-peer channels of communication, case complications, how we can do things better, questions that we have, because it's also new to us, to all of us that are a part of this organization or have been to any of its meetings. So that is in my humble opinion, peer-to-peer and minimally invasive, lots of potential.
Yeah, no, you know, as somebody who's been in education for over 3 decades, I want to just applaud you for doing what you're doing, because I think being able to share all that information that's also valuable to so many people is so key. And I would encourage anybody that involved your organization, just remember, you know, knowledge is the power, but you have to apply it. And so again, we talked about earlier, the integration is so key, but that is so cool what you're doing. Thank you for sharing that. There were a couple of questions that came in, and I just want to hit, you were talking about how you do your case presentations. Do you also talk to your patients about the finances?
Yeah, I have I use UCR fees in my office are based, I take only PPOs, certain PPOs. And if you have PPOs, we got to go by their rates because of contracts and all of that. I'm very disliking the whole insurance industry. Dr. Blatchford is an expert. Bill Blatchford, he has podcasted with me. He's coming on our program in a couple of days. His recommendation is that you don't even take insurance and you give them their receipt and tell them to contact their insurance themselves. Some people find that hard to do, but he says he has much success with it. I still play a little bit with insurance organizations, but ultimately I like to get half of the monies up front and half the monies on the back end. That sometimes is also the factor that convinces patients to go on the other side of the fence versus walking away from it. So the tipping point is usually when I present a treatment plan, and if it hits their eyes as a high number, we start explaining to them that, hey, sometimes we leave these implants in there for 3 months, 4 months, 5 months, 6 months. So you don't have to pay the other half until the prosthetic is done or what have you. So they get the thing. And with MagiCore, you have a little bit more of a playground because you don't have another abutment to charge out for and all of those things. You can make it very affordable for the patients and also explain to them that they can have more time to pay rather than compensate you all up front and have the financial challenges. And then there's also a lot of financing companies, not just Care Credit. There's a ton of them. There's some financing companies that finance $40,000, $50,000, $60,000 treatment plans. You have to seek those out and engage with one of them. I use like 3 or 4. I'm using Lending USA, Proceed Finance, Healthcare Finance. I use some Care Credit, but they're always after the best credit scores, and they don't do much on the B paper side. So you have to know them and kind of route those applications to the one that you believe is most likely going to be able to finance it after the first rejection.
Yeah, no, I absolutely agree. I'm glad that you could clarify that. Well, we're coming up on our hour, so I just wanted to let you know, Dr. Shah, that I appreciate you sharing so much with us today. I enjoyed the journey. I learned a lot, and I'm inspired. And your what I consider invaluable thoughts on our profession, on implantology, on the way you practice. They're very insightful, and I hope those of you that listened or watched the program were able to take away some pearls from this that will help you build your practice, especially after this COVID. To our new and growing OMI community, please send us your comments, suggestions, and look out for the next invitation to join our next OMI Live interview. And I think what we have to really do is stay focused again beyond this coronavirus. Let's support each other. That's what the community is all about. And let's design our post-COVID future of success, offering our patients the very best. Just remember, as Dr. Shah was talking about, offer your patients the best, talk to them, help them understand what it is that we can do. And I think we're going to come out of this a lot better than most of our other colleagues. So Dr. Shah, thank you. And to everybody who watched, thank you very much. And we will see you all again soon. Take care.
Got it. Thank you for having me on the show, and I much appreciate your time.
Thank you. Great job.
Take care, Doc.